Antifungals. So there are different groups of antifungals. Choline, then echinocandins, then heterocyclic benzofuran, and the azole group. It contains imidazole and triazoles, then allylamines like terbenifine, and there are topical agents. So we'll discuss further about these classes with the action. So if you go back, let's say echinocandins. Examples, caspofungins, micafungins, and annullafungin. Mode of action, inhibition of beta-1,3-D-glucan synthesis. So you can see here 1,3-beta-glucan synthesis. Beta-glucan synthesis. 1,3. Okay. Some fungi like Cryptococcus, they contain 1,6 and even muco. Like so, you wonder whether they act or not. Here it is 1,3-beta-D-glucan is part of cell wall. So it inhibits the beta-D-glucan synthesis. So end product is fungal cell wall. Without beta-glucan, cell wall becomes weak and leading to lysis. So echinocandins we usually commonly perhaps use for Candida species, specifically Candida albicans, Gabrat and Cruciae, and also for the Aspergillus species. Just excuse me. So, like Candidemia, isopropyl candidiasis, invasive candidiasis, even aspergillosis we use. Common adverse effects are hepatotoxicity, liver toxicity, and also it can cause infusion-related reactions like hypersensitivities, leading to fever, chills, and phlebitis. Hepatotoxicity, we have to monitor the liver functions, transaminitis, liver enzymes, and based on the liver healthiness, we may give the full dose or maybe adjusted dose. About the azoles. So azoles are common. We are imidazole and triazoles. Azoles action is inhibition of ergosterol synthesis, which blocks the enzyme lanosterol 14-alpha demethylase, which converts lanosterol to ergosterol, a key component of the fungal cell membrane. This leads to membrane destabilization and leakage of cellular content and disrupting fungal cell functions. You can see here how it affects, how the source works and how it affects gistol into lanosterol. Then polyenes like amphotericin B, nystatin, lipid formulations are there back of binding to ergosterol. So you can see it's bind to ergosteroids. Polyene bind to ergostol, a major component of the fungal cell membrane. This binding leads to formation of pores or channels, disrupting membrane's integrity and causing ion leakage, specifically potassium and magnesium. This results in cell death. So you can see how they act, polyenes, cell membrane, leading to loss of various ions. So side effects like main is nephrotoxicity and infusion-related reactions, and also electrolyte imbalances. So there are different formulation of amphotericin B. We'll discuss later, like lipid formulation and conventional formulations. And nystatins are there. So they can use for the Candida species, Aspergillus species. Azoles we use for Candida species. But commonly echinocandins are used for, that is the first therapy, the first line therapy for Candida species, but it's not available in Sri Lanka more often. That's why we go with the azoles, but azole resistance is a concern. So you have to look up which Candida species are resistant to azoles, like Candida krusei and gabrata. So then we next option is polyenes, like amphotericin B. So when we give conventional amphotericin B, we have to lot of cautions. Prehydration, post-hydrations, likewise. And electrolyte monitoring and give the dose slowly covered with the aluminium foil because if it is exposed to the sun, the drug, it may lead to various reactions and change in the chemical nature. And it is highly nephrotoxic. That is the main concern and infusion-related reactions similar to other. Azoles, there are novel ones like voriconazole, isovuconazole, and voriconazole often we use for aspergillosis. Isovuconazole also for this as well as we may use for mucormycosis like conditions. For a mucormycosis, Pauline is the most important therapy. And allylamines. You can see allylamines, how they act. So it is not mainly given here. So it is mainly by sequelin epoxidase. Allylamines inhibit sequelin epoxidase and enzyme involved in the biosynthesis of ergosterol. So that is the previous step of ergosterol synthesis. Azole acts ergosterol to lenosterol. You can see, sorry, it's actually sequelin to sequelin epoxide, then lenosterol and ergosterol. That's how it goes. So, allylamines often we use as a topical therapy more often, has a hepatotoxicity and GI disturbances. Often we use for tinea infections and onychomycosis, nail infection, fungal skin infections. Then about the flu cytosine. It is inhibit the DNA and RNA synthesis. You can see here how it affects. You can see here it is anti-metabolite group. So when we ask in the group, you have to go ahead with the antifungal group, polyenes, echinocandins, azoles, allylamines, and antimetabolites. And you want to target which antifungal is for candida, mucormycosis. Dermatophytes, often we use that is cryptophyllin, or maybe azoles like itraconazole, fluconazole, and things. Voriconazole, as told earlier, it's for aspergillosis. No use for candidiasis. So mode of action, again I'm recalling, azoles how act, terbinafine how act, then flucytosine, then amphotericin B, echinocandins, then rhizophillin, microtubular synthesis inhibits. So it's usually used for the dermatophytes. So those are the side effects related to flu cytosines. And we often use for candidiasis, yes, and cryptococcal meningitis, first line therapy. But often we give cytosine with the combination. Rather, we don't give alone because it has a high tendency to develop resistance. Has a bone marrow suppression element and hepatotoxic. You can appreciate all the hepatotoxic. So when we are prescribing antifungal, we need to check the liver functions and polyenes nephrotoxicity as well. Bit of about amphotericin B formulations. Type of amphotericin B conventional, then liposome. So conventional versus liposomal or novel formulations are there. Conventional, these are the liposomal, amphotericin B lipid complex and colloidal dispersion. At least conventional amphotericin B and liposomal amphotericin B, if you know, that's enough. Both action more often similar, binds to ergosterol in the fungal cell membrane. It binds to cell membrane. Forming pores, same mechanism. Liposomal also encapsulated. Lipid bilayer, which are target to improve the drug delivery to fungal cells, much more improved lysosomal form. Reduce the toxicity because this is highly nephrotoxic, conventional form. And also infusion-related reactions, electrolyte imbalance, anemia, all can cause, but liposomal form and rest, nephrotoxicity is less compared to conventional form. Infusion-related reaction, electrolyte imbalance, hepatotoxicity, more towards same. Others also as such. So you have to have antifungal classes and groups idea, mode of action we have discussed, and dermatophytosis, zoonogracefulin, candidemia. There are several antifungals. First line therapy is echinocandin, which is not in Sri Lanka, so we go ahead with azoles, or else we go ahead with amphotericin like polines. Then antifungals for mucormycosis. So it is highly resistant pathogen. Often we may go in with amphotericin B. Common adverse effects, hepatotoxicity and nephrotoxicity, amphotericin B, then infusion related likewise. Then how to use conventional amphotericin B? Often we have to give pre-dose fluid like IV normal saline before they start in the therapy and give the dose, and after dose, then we have to monitor the response. I mean, is there any reactions? Then definitely we have to stop it. And also drug should be put into the drug distiller and which should be covered with the aluminum foil.